Good afternoon, everybody. We're just letting everyone join. We've got over 550 people registered, just clocking through 100, 120 as those people log in. So we'll just give them 30 seconds or so. Very good. Well, look, I'll kick off. First of all, welcome to everybody. And we've got a fantastic lineup today. The topic is how COVID is reshaping the markets. My name's Henry Elphick, I'm the CEO of LaingBuisson, and we're delighted to be putting this webinar on in partnership with Charles Russell Speechlys, the law firm. We're going to start just with a couple of housekeeping things around the technology. The first is, if you look at your Zoom, you'll see there's a chat function at the bottom of the screen. Please feel free to use that chat during the webinar if you've got views about what is being said, and you can address that to the panelists or to the audience, and people I hope will be interactive during the course of the webinar. However, for Q&A, in order for us to manage the Q&A, we're going to use Slido. We've got hundreds of people on the line. So if I could ask you also to effectively log into slido.com on a smartphone, on an iPad, or in another browser on your computer. It's very simple. Literally just put Slido in the search bar and you'll come up with a screen which says joining as a participant, and where it says enter the event code, just put in the words social care. Join an existing event and you will end up with a screen that looks somewhat like this. And this allows you to click on the Q&A and ask the speaker a question. So type in a question here and then click ask or return. Alternatively, you can click on the polls and participate in the poll that we're going to run. And the main reason for this is we get lots of questions and you can upvote the questions. And when we get to the Q&A at the end, this allows us to identify the questions that people in the audience are most focused on. So to test people's proficiency at this, we're just going to go to our poll for today. I can see that 15 people have managed to log in so far. So the poll question is, what will be the biggest benefit of COVID? Will it be the better discharge of patients into social care and health and social care being better coordinated? Will it be the real use of digital and data? Will it be better cooperation between the private sector and the NHS? Will it be more system funding for the NHS and social care, not just for the NHS? Or will it be improvements to the supply chain across the system? We've seen particularly with things like PPE, how that has been suboptimal at times. So we'll let that run in the background. Whilst that's going on, we'll come back to it at the end. I just wanted to turn to some of the questions that attendees have been asking us to set the scene. I thought actually the best one was, if you could go back in time, what advice would you give yourself in order to handle this pandemic better? And that's a sort of an interesting question for all of us, whatever sector of the market you're active in, or indeed whether you're an advisor or a provider or a regulator or a funder. Are providers prepared for the second wave? How will UK employment rules collide with the pandemic? What are the supply-demand dynamics around bed availability and pricing? And again, that appeals to all the different sectors of the market. And lots of questions around funding, which we'll come on to. House of Lords has said we need 8 billion. Questions around the healthcare market, what happens when the NHS comes back online? And then the real focus is around social care and education, and effectively what will happen post-COVID. Will there be changes in the way that facilities are built? Is there additional capex that people will have to spend? How can we mitigate the concerns that service users naturally have about moving into care homes? And what's the public perception around a number of these markets? So some really good questions. And we've heard throughout the webinars we've been holding a number of themes emerging. The speed of change has been remarkable. We know there's a lot going on around PPE and testing, all around digital, but funding and regulation are really where we're focused on now. So we've got a great panel. Michael Lingens, who's a partner at Charles Russell Speechlys, will introduce the session and set the scene with some of the dynamics that we've been observing over the last few months. Farooq Sheikh, who's the Executive Chair of CareTech, will then follow. And CareTech, post the acquisition of Cambion's business, has really a foot in multiple camps across education, adult social care. So has seen perhaps a broader breadth in its businesses than many others. We're then delighted to have Professor Martin Green, CEO of Care England, to talk about the care home market. And I'm really delighted to have Martin on because he's been giving evidence to Jeremy Hunt and the Health Select Committee. And Dr. Natalie-Jane Macdonald, who's now wearing many hats, but one of those hats is CEO of Sunrise and Gracewell, who can talk to the care home market from the perspective of a private pay provider. But her other hat, most recently, is to be the chair of Nuffield Health. So many congratulations on that. And I think if we can have a look at the perspectives that perhaps that hospital market is looking at as well in some remarks, that would be great. And then that leads into Katya Subareva, who's a partner at L.E.K, who've got some fantastic data in a survey they did as the pandemic hit around people's attitudes to private pay across the hospital and the clinics market. So today we've really got a spectrum right from education, adult social care, care homes, hospitals, and clinics. So I think we'll get a fantastic perspective on what is reshaping these markets. So on that, I will hand over now to Michael Lingens from Charles Russell Speechlys to set the scene for us. Michael, over to you.
Good afternoon, Henry. Thank you very much for the introduction. Charles Russell Speechlys is an international law firm headquartered in London with over 500 lawyers. I say headquartered. In fact, our headquarters has been closed for the last 3 months, but like everyone else, we've been working from home, but quite effectively, if I may say so. The slide tells you a little bit about the firm. I head the healthcare team, which has roughly 40 professionals working regularly in the sector, across the sector, notably in social care, but also retirement living, medtech, dentistry and pharmacy, and we provide a full range of transactional advisory and dispute services. That's enough advertising. What's my personal interest in the sector? Well, as well as being in charge of the healthcare offering for my firm, I've been involved personally in the healthcare sector for some time, and it stems from my involvement in the mid-80s as London Borough Councillor specialising in social services, when of course we were on the cusp of what then became a radical transformation of the way in which care was delivered and funded. I've also previously been a non-executive chairman of a PE-backed care home operator. So, Henry, next slide, please. And so it's from that perspective that I offer some thoughts on what might be the potential longer-term impact on the social care sector. I say social care, but I think inevitably the focus is going to be on the elderly care subsector, at least in the immediate future, especially in care home settings. Why? Well, roughly 35%, a third of all COVID-related deaths had been in care homes, which has been a similar experience in many other countries, but nevertheless offers some valuable lessons for the future. And as a result of that, there's been a huge focus on the adult specialist care, on the adult market. And a lot of the focus has been on its weaknesses, whether it's in terms of care delivery or funding or how it's organized. But I have to say, there's also been some positives, some silver lining out of all this, which is that the public have, I think, finally recognized that there is an immense social value to social care work. And as an example of that, early on in the crisis, the Thursday clap was for the NHS and the healthcare workers, and then, admittedly under some pressure, it transformed into clap for carers as well. And I think there's recognition that social care workers are an essential part of the overall healthcare system. So what lessons can be learned, and what is the longer term impact? I'm going to talk in three rough areas. The operational impact, staffing, some important points on staffing, and then more longer term, what the funding and also potentially structural changes are to the social care system, or what they might be. In relation to the operational side, clearly lessons learned are that there has to be ready access to supplies of PPE, that there has to be comprehensive testing and infection control processes and training across the sector, but notably in the care homes that I've been talking about. There has to be more rigorous procedure for making sure that people are tested before the discharge from hospitals into the care home setting. And also, in many quarters, care homes are going to have to be reconfigured, not just potentially for a second spike of this pandemic, but also for any future epidemics that may emerge. Longer term, will there be a shift from residential to, say, home care or other retirement living, or in the specialist sector to assisted living settings? I think within elderly care, there will be some shift there, but probably at the margin. And why is that? That's because the nursing care that's provided to the 400,000 or so patients in this sector, especially where they're high acuity, which most of them are, better care is going to be delivered in those settings, and it's going to be delivered more economically. So I don't think it heralds the end of the care home sector, as some have been saying. In relation to staffing, well, we are heading for a recession. There's going to be lots of unemployment in other sectors, which you're familiar with from your general knowledge of the economy and what's going on. But the social care and indeed the healthcare sector may stand out because it will be offering potentially more jobs, particularly if staffing ratios are to improve. And that is an opportunity for the sector, because the social value that I've highlighted earlier on might attract more people to work in the sector. And incidentally, that might mean if there's a bigger pool of available UK workers, then the emphasis there's been about immigration controls in the light of Brexit might correct itself in the medium term. However, employers have to do their bit, training and career frameworks probably led by the larger employers to make sure that the staff that are recruited are retained for the medium and long term, and that work in the social care sector is recognised and is recognised as important in society. And part of this will also include, in my view, improving pay. Too many people are working in the care sector at or just above national living wage levels. Employers need to take a look at sick pay, particularly for workers in this sector where there's a higher risk of infection. But many of you are saying, well, hang on, all that means different ways of delivering care, more expense, and paying people more and more people to work in the care homes to make them COVID-proof and so forth. All that's going to cost money. And how can we do that when, especially in the elderly care sector, occupancy has declined in the last 3 months and has led to some employers teetering on the brink of insolvency. So now is not a good time to be asking them to make all these investments, which leads on to the funding debate, the eternal funding debate. So let's look at what's been happening in the short term. Well, in the short term, the government, with much fanfare, announced at the beginning of the pandemic a 3.2 billion grant to local authorities to help deal with the COVID response. Well, how much of that trickled through to the social care sector? I suspect very little. I was talking to one of our clients, a care home operator with 70 homes up and down the country and across about 30 different local authority areas. Out of that 3.2 billion, they saw a grand total of £250,000. So virtually no support at all, given the operational stress they've been under. The 600 million, however, which was earmarked for capex related to better infection control and other measures, that does seem to have got through a bit more effectively. And the same operator I was just talking about is in the process of recovering their hope, around 3 million, which is a help. But it is a reimbursement mechanism and doesn't actually add to add to the top line. So the key question is whether the frontline status that the pandemic has put the social care sector in, whether that will give rise to sufficient political pressures to encourage the government to undo the purse strings even more and provide better funding. There's also the hint, in fact more than a hint, on Tuesday in the Prime Minister's speech in Dudley, that they are, he said, finalising proposals for the reform of the entire social care system. I suspect focused again on the elderly. And so it remains to be seen what emerges from that. But the fact that it's been so prominently signalled now as being nearly ready, I think is encouraging. Just one word of, one observation about that is that if the direction of travel for reform is that individual contributions to their long-term care is to be capped, which is generally the theme, of reform proposals, that might in the current climate be regarded as more intergenerational unfairness, with baby boomers like myself, being subsidised yet again, in terms of contribution to long-term care. And I suspect that in exchange for that, the government will look to impose some sort of levy, social care levy, by way of a hypothecated tax of some sort, probably for the over 40s, anyway, the elderly society who can afford to pay it more in general. One final thought is in relation to how social care is organised and delivered. Now, the Labour Party talked in the last general election about a national care service. Now, I don't for a moment suggest that nationalisation of the sector is on the cards, although some are calling for it. But what we might consider is some sort of centralised agency, like NHS England and its counterparts, that would, say, take over the local social services departments and operate social care on a unified national basis. What would be the benefits? The benefits would be common commissioning standards across the UK. In other words, who is entitled to what and when, rather than the postcode lottery that operates a lot at the moment. Secondly, you would have standardised fees across the UK, not the myriad of haggles that go along that go with the current system. You could, that would then free up the local delivery units, in other words, the old social service departments, to concentrate on decision making on care pathways, including those agreed with the local NHS trusts. And crucially, it would be a more efficient mechanism to deliver increased funding to the social care sector directly, rather than routing it through the local authorities, then have to balance that with the other priorities. Against that, any organisational change by government is going to be hugely disruptive and costly, and it may be that the judgment is that there are too many short-term pressures to make that a realistic objective. But nevertheless, offer that as a thought. But put all that lot together in terms of changes in operational delivery, improvements in staffing, hopefully this giving rise to more better funding, and reforms to the overall social care funding and potentially delivery system, that could be a new deal, to coin a phrase, for the social care sector. Those are my thoughts. Thank you, Henry. Back to you.
Michael, thank you very much for that. And look, that was a very comprehensive overview. Those three pillars there, it'd be really interesting to hear from the providers. Operational, my gut sense is the sector has really stepped up operationally, and we are much better prepared for the next wave. We were handicapped in the first wave by government and the NHS. On staffing, I think the image of the sector has been totally rehabilitated. And actually, as Farooq was saying just before we joined this call, the resilience of the sector and the stability of the sector as an employer has been emphasised. And on funding, it's interesting, on the poll, funding has actually been pushed into second place behind digital and data. And I wonder whether actually it isn't all about the money, it's about being smarter as well. On that, I'm delighted to welcome Farooq Sheikh, who has been very much at the coalface for this pandemic. And Farooq, just to hand over to you to tell us a bit about CareTech and your experiences.
Thank you very much, Henry and Michael, and thank you very much for organizing this webinar, and a very warm and a good afternoon to all those on the webinar. My name is Farooq Sheikh. I'm Executive Chairman of CareTech, and I think I've been lucky enough with my brother to set up CareTech some 25 years ago. And I must say, for us, it's been an incredible journey from a single home back in 1993 to having over 550 facilities around the country today. Along that way, we've had 2 rounds of venture capital finance, and Michael has helped us on that journey over many years through his sort of trusted advice. And today, and we listed in 2005, and today we're a leading national provider of care services for adults and children with complex needs. Our main focus for the young people that we support is about providing positive outcomes for them and creating a care pathway where they can live more independently, and therefore we can reduce the cost for local authority. Our real USP is our staff. You know, they're a key to our success. And in CareTech, and it's one of the reasons why we floated, was to create a culture of staff empowerment and a culture of share ownership. And I'm proud to say that we have over 10,000 or 11,000 staff, up to 1,000 staff that are shareholders in the company. And having well-trained staff, having motivated staff leads to good quality ratings. And we're blessed with some of the industry-leading Ofsted and CQC ratings. And no matter whatever you do, you can never do enough. And we've grown over the years from a combination of organic growth, bolt-on acquisitions, and as Henry said at the beginning, we bought Cambion back in 2018. And with that, you know, we have become one of the largest providers of education and residential services to children in the UK. But despite the growth that we've had, we still have less than 5% of a market. There is further consolidation in the market. And, you know, we look at international and technology as other growth points, which I'll speak about. Just the next slide, Henry. We see CareTech very much, we position CareTech as a partner. Over 25 years, we have built a reputation with local authorities that we work with them to help them on the issues that they have. The demographics people will be familiar with. We have got a population where the 15 billion social care market that we operate in is getting bigger. There's pressure on budgets, there's a need to outsource, and they need to find good, trusted providers. And we have a very, very fragmented market. For us at CareTech, we focus on deliver on the individual. We focus on providing person-centered planning, and we focus on trying to give those individuals the support that can help them to live as independently as they can. Just the next slide, please, Henry. So, just the next slide, please. Sorry. So we've listed in 2005. I think there's one thing that I'd say about the social care sector that we are in. I think despite all the challenges, I think we have a resilient business model. We've grown, and the demographics of the sector that we're in remain unchanged. And we're one of the few companies that actually is still paying a dividend and growing its dividend. From the charts that you can see since we've listed, our revenue, EBITDA, and EPS has grown by a CAGR of 21, 25, and 16. And what that has shown to the city particularly is really, as much as we are in favor or out of favor sometimes, that this is a sector that is robust. It is a sector that can withstand Brexit. A sector that can withstand financial meltdowns, austerity measures over many, many years. And COVID crisis has been probably the biggest disruption to business that we've ever seen, or most people have ever seen in their lives. For CareTech, it has presented challenges, but I think unlike the elderly care sector, we look after young people, and they're not the high risk or the vulnerable. So we've been very insulated from the infection side, from the young people that we look after. Local authority have wanted us to keep our services open. So all of our 550 homes have remained open. Some of the daycare centres we've had to close because obviously people can't go to the daycare centres. And local authority have been very, very upfront in helping to fund and make sure that they do provide funding. And when they've been paying monthly, they've come forward to say, can we help you to pay weekly? So look, it's a business that's been resilient. It's a business that has maintained its cash flow, unlike many other businesses in these times. And one, as a public company, we're probably one of the few companies that has maintained its guidance and paid the dividends. The main issue that we've had, and Michael spoke about this earlier, was around staffing. And our main issue was around how can we maintain safe services when people are self-isolating. Of our 11,000 staff, we probably had 900 at the highest point self-isolating. And and I can pick this up in Q&A, but we set up a task force, we set up a dynamic risk assessment tool, we monitored each service on a daily basis, looking at how are they dealing with staffing, what are the pressures, and we set up budgets and flexed the rotas where even if we had up to 20% of our staff not in, how can they manage their services safely? Speaking to local authority, they were keen for us not to use agency because that represented a risk. And I must say technology really, really helped us to manage the business efficiently. One of the challenges we had, and Michael spoke about this, is really SSP, as people were self-isolating, became a real issue for some of our frontline staff. And we took the decision as a board that we would launch a support fund before the funding came from local authority of up to £1 million to help those people that were on SSP. I mean, unfortunately, SSP pays £95 a week. For the average support worker earning £400 a week, they can't live on £95 a week. So we launched that support fund of £1 million of our own back to help some of our frontline staff because we felt we had to do it. And that went down really well. But the funding that came from government, and again, I can pick that up in the Q&A, we felt actually has been very helpful. It's not easy to get funding because you've got lots of forms and things to fill in, which are never easy. But I mean, it's something that I think the government has sort of come forward with. So look, I think for us, I do see a situation where COVID-19 has been a disruptor. I think for our sector particularly, I think we've seen that actually it's been quite robust. And I was saying to the panelists earlier on, we see an opportunity that actually it's an opportunity for us to actually put forward a case where we can be really credible employers and employ people. Many people have been making people redundant, and create a career pathway for people in care out of choice rather than out of necessity because they can't do anything else. So look, as far as we are concerned, I mean, we are dealing with the challenges that this brings. We've learned a lot of lessons through this. But equally, we are looking at the future with our guidance intact. So our market guidance remains as it is because we feel that, you know, our underlying businesses are strong. And we feel that actually there is an opportunity for the right operators to consolidate the market and still grow because the underlying fundamentals of demographics and growth don't really change. So maybe if I'll pause there and allow other panelists to, and then we can pick it up in Q&A.
Farooq, thank you very much indeed. I think my takeaway from that is that clearly there's a remarkable story with CareTech. You've been unusually public because you're listed, so there's a level of transparency. But in some ways, you've been lucky as well, just by virtue of the fact that your resident service users fall into a cohort that haven't been particularly impacted by COVID. But in terms of what's changed, it sounds like actually around staff, just using technology, being flexible, supporting those that need it, incentivizing people with equity have all worked well. It'd be very good in the Q&A also to pick up on how you think COVID has actually changed the market and maybe some of your relationships with the local authorities as well, because I think that's also where people are really focused. We've had this shock, and hopefully there will be some silver linings. And I think technology sounds like one of them that came out of what you were saying. So on that, I'm delighted to now turn to Professor Martin Green. Martin has been in the thick of things, both in terms of championing the sector with government and his members, but also I think in terms of just having access to providers and politicians and members of the Department of Health and Social Care. So I get a fantastic perspective of what is going on, but again, most importantly, what is likely to happen next. So Martin, over to you.
Thanks very much, Henry, and good afternoon, everybody. And thank you, Henry, for putting on this seminar, which I think is a really good timing, actually. And I want to talk about some of the things that have happened, but I also want to talk about what I think that means for the future shaping of the market, for the sector in general. And the point I also want to make is that I think this is a moment in time and there is all to play for. And if we're not careful, we might see, as things start to plateau, us trying to be pushed back to where we were. And as a sector, we must not let that happen. We must let the lessons of COVID have a lasting impact. I gave evidence to the select committee, which was looking at the COVID-19 outbreak and looking at how the whole system had responded. And also what was very interesting in that session were some of the other people who gave evidence were from other areas like Hong Kong, like Germany, and they had dealt with this pandemic in slightly different ways and had different outcomes. So I do think that from this, there are big lessons to be learned about how we move forward. I first of all want to say that I think at the start of this pandemic, what was very clear was the underrepresentation of social care and the fact that social care was not seen as an integrated part of a continuum of health and social care. And the entire focus of everybody at the start of this pandemic was the NHS. And I think the lesson to be learned from that is that we must not in the future focus on organisations, but we must focus on the people in most need. And if you look at the demographics and if you look at the levels of comorbidities of people in care services, quite clearly they were the ones in most need, and we should have prioritised them. Instead, what we saw were people like primary care completely withdrawing from the field. So social care was left without proper support. We had primary care telling social care that, for example, in older people's services, they were not going to do any connection with the care home. They were not going to send anybody to hospital. And in some cases, they even said you must write "do not resuscitate" on people's notes. Now, I cannot imagine any other particular bit of the sector that would have been treated like that. And what I think this exposed was not only the position of social care, but also the ageism in our system. And no other client group, I believe, would have been treated in the way older people were. Now, contrast that with the way in which they dealt with this in Hong Kong, which was the moment anybody showed anything like a COVID symptom, they were taken straight to an isolation hospital and given high-level support. And that produced a significant reduction in death rates. So I think there are some big international experience that we can also draw on. I also think there have been some big areas where we have seen the fault lines in health and social care, and what we need to do is we need to close the gap. Well, the first thing to say is around funding. One of the challenges in social care is that we have always been pretty underfunded. And also, because we're a sector that has private companies as well as organisations that are from charity bodies, etc., there is always this attempt to sneer at us because we use investment and we also make profit. And interestingly, I was on the Today programme, and it was a programme focused on COVID. But Nick Robinson, the interviewer, could not help but throw a very stupid and banal question at me and saying, oh, you know, everybody in social care is making a fortune. Isn't this a disgrace? You know, I could have kicked back. And what about all the NHS trusts that have had their deficits wiped? Isn't that a manifestation of bad organisation and bad running of the service being supported by government? So I think we have a real problem about that. I also think the government has completely shot itself in the foot, because in the last 4 months, we have seen about 400 million extra going into the whole of the local approach to social care. But that money is not reaching the front line. Some areas they've given ridiculous administrative processes. Some areas have not contacted care providers. Some areas have offered very small increases. And this is a real manifestation about the mechanisms to deliver funding, and they need to be changed. Localism is not fit for purpose in relation to this. So I think we need to take a long, hard look at how we distribute the funding that's available. Because there's no government in the last 40 years that has given this amount of money, and yet the impact of this, which could have been huge, has been dissipated because of the mechanism of delivery. I agree absolutely with the points that both Michael and Farooq have made about the workforce. One of the things I think has really come across in this pandemic is that our workforce are really skilled and they have stepped up at a time of crisis. And interestingly, there were loads of times when our workforce was told, oh no, you haven't got the skills to do a raft of different things, and the NHS would have to come and do them. And then suddenly the NHS ran for the hills, leaving our staff to do that work. So I do think we should have a long, hard look at the whole workforce agenda. We need to change the way in which we perceive social care workforce. They need to be on the same status as the NHS. We need to start thinking that if we've got an integrated system, we need an integrated workforce strategy. We need common cause and skills competencies. We need the enormous amounts of money that's in training for the NHS to be rolled across the system. So we've got £100,000 a minute being spent on training in the NHS, and the Skills for Care budget is about 21 million. Now, this is not fit for purpose. So we need to take a long, hard look at the remuneration, the training, and the career pathways in the social care sector. But also, if we're going to have an integrated system, we need a workforce that will move seamlessly from one system to another. So again, we've got to take account of that in how we reconfigure the workforce. I think there needs to be a different approach to regulation. And I think the regulator has shown itself to be, shall we say, pretty lackluster in this crisis. So for example, I challenged the regulator at a time when we saw primary care withdrawing from care homes as to why they weren't taking enforcement action on some of those organisations that were either withdrawing services or indeed on hospitals that were discharging patients without COVID-19 tests. There is a big challenge there. I would say also that not only the regulator, but lots of these quangos have found themselves not fit for purpose. So we've got a situation where data has not been delivered in real time. And the ONS has been giving us data that has been 12 days out of date. In a digital age, there's something fundamentally wrong in that organisation. And some of these things require not only structural change, but cultural change. And when we put forward the figures of people who died in care homes, and I knew the figure was about 7,100. The ONS figure told us there were 217 deaths. Now, there is a long way between those two figures, and there needs to be something done about getting that organisation into the real world of the 21st century. The other issue was about Public Health England, who was slow to deliver guidance. And when it came, it was like a blizzard. And quite clearly, some of it was not fit for the social care sector. And in one case, we had 6 pieces of guidance within 2 days. And partly that was because they were issuing guidance on a sector they didn't understand. So I think there is a big question to be asked about some quangos. We need to ask what their purpose is. We need to revision them, and we need to change their cultures. And we need to move them into being a support to the system rather than something that is weighing it down. My final point is about how technology has really been accelerated during this pandemic. And, you know, we've seen that in terms of the collection of data. We've seen it in terms of the way in which we've used technology to, for example, engage with different bits of the system. And so we need to make sure that the gains that have been made with technology and the efficiencies and the better quality outcomes that have been delivered because we're becoming more technologically savvy are maintained into the future. I said at the start of this that we have all to play for. And I want to remind people that I think if we're not careful, as the pandemic starts to plateau, as people start to move towards business as usual, there is a danger that our sector will slip back to where it was. So it's incumbent on all of us who are in it to make sure that we first of all have a clear vision for what we want and fight tenaciously to make sure it's delivered. Thank you, Henry.
Martin, fantastic. I mean, a very incisive, succinct summary of where we are. And I think it really also focuses us on the key issues. Funding, where I think you were making the very valid point, it's how it's distributed as well as how much there is. Workforce, where it's about the fact that people may be low pay, but they're not low skilled. And we need to think about the mobility of that workforce between social care and healthcare, around regulation, where I think we absolutely need some structural and cultural changes there. And I think the political winds around Public Health England, I'm not sure that organisation is going to survive this pandemic. And then finally around technology and data and making that real time. And I think there are a number of initiatives there, but there is no doubt you can respond to anything if you have proper, accurate, real-time data, and that reduces your chances of getting it wrong. So I think there are a lot of points you've made there, and some really interesting themes. So look, I'm now going to turn over to Dr. Natalie-Jane Macdonald, who has also been experiencing this as a provider in the front line, just to hear a little bit more about how Sunrise and Gracewell have been doing it, but also how some of those themes perhaps you see impacting the sector and the market as we look forward. So Natalie-Jane, over to you.
Thanks very much, Henry. Thank you for giving me the opportunity to join the panel. So just a tiny little bit of context. Sunrise and Gracewell serve just under 3,500 residents here in the UK. And as Henry said at the beginning of the webinar, we are largely focused on the private pay market. Around 10 to 15% of residents in Sunrise are funded, and just over 20% in Gracewell. So obviously everything I say has to be taken in the context of the experience that we have with the residents whom we're here to serve. Our average length of stay in Sunrise is about 24 months, and in Gracewell around about 16 months, which I think is a helpful context in terms of the role that care homes have in terms of the provision of care and support to older people who are finding it difficult to live independently. I think care homes are for those who are getting towards the end of their lives, or as Camilla Cavendish was described as the old. Our experience, some of what other speakers have said, I would endorse, and definitely have seen some of that. But we've seen big variation, I think, across the country. I think residents may be the same age chronologically, but biologically, depending on where they've come from, where they live, and the lives they led earlier, kind of a big difference on their ability to withstand something like COVID-19, and that has an implication on death rates. And all the other things that we've heard about, such as the availability and utilisation of PPE, whether or not homes accepted patients coming out of the NHS, tested or not, and the impact that had on bringing infections into the homes. And I think that really varies tremendously across the country and across different providers. Clearly, we're all faced though with something that has been extremely costly to be able to deal with. Millions of pounds spent trying to protect residents and protect team members who look after them. And as has been said, it's wonderful to get funding, but as Martin points out, the funding is too late because much of it is not retrospective, and we can't spend the money that we're getting because we've already spent millions and millions of pounds already on protecting our residents, and that money has gone, and these funds are not retrospective. And at the same time, we know that there are the risks of recurrent infection and being ready for that, at the same time as having team members who've worked tirelessly over the past 3 to 4 months and are tired, and yet aren't even going to be able to go on holiday probably abroad, or if they do, they're going to have to isolate when they come back. We don't know, and what that means for them. So I think that there's a general sense, and I don't think it's peculiar to the care sector, which is that when you're trying to lead and run businesses, serve customers and lead your teams, the advice and the guidance and the policy making needs to be cognizant with what it takes to do that and be forward funding and on the front foot. And it has been very difficult to do that all the way through because of often too little too late. And I think particularly we're still seeing the fact that we don't have an effective testing program in place. We're putting in place our own testing program of 2-weekly testing for all our residents and all with consent and our team members, so that we can try to keep COVID-free homes. But we're doing that absent that being put in place and available for us and for other providers. I think one of the other big things is there was clearly a tremendous amount to do at the outset of the pandemic in order to equalise the perception and the treatment and the position of those who work in care versus those who work in the NHS. Our people and all those who are working with other care providers for all sorts of residents of different types have worked as hard as others have in the NHS, and there is a huge job to do to equalise the treatment of them in relation to the media, and I think a fantastic job was done on that. And equally, where PPE was not available and there were issues, it was important to draw attention to that. I do think, however, that unfortunately nobody likes good news stories, and we are left, unfortunately, with an immediate legacy that there is a strong perception among many people in the country that care homes are not safe places to be, and that going into them risks acquiring COVID-19. Or the other big fear is that should there be a second wave or should an outbreaks recur, you will find yourself having made a huge life-changing event and going into a care home only to have the doors closed and you're not able to see your family and they not to see you physically at close quarters for many weeks. And of course, that is a legitimate fear. In terms of next steps, I just wanted to focus on three things. First of all, I think in the longer term, one of the things that this whole exercise has emphasised is the importance of there being choice and different options for older people of our population as they grow older. I don't think it's an issue that that care homes are finished or anything like that. But I think choices around strong domiciliary services, strong retirement living and other sorts of supported living, and a very strong network of care homes are all essential components of being able to be there for people at whatever stage in their life they are, and particularly for the very frail and for those who have advanced different types of dementia. Care homes have an absolutely vital place and provide unrivaled and amazing services often to the most vulnerable. I don't see that changing. However, it is clear that in providing care in care homes, we need to look at their design, their construction, to make sure that this will not be the last infection of this nature, that infection cannot spread easily within them, and that we have to have better recourse to protecting residents than locking them up and not letting anybody in and not letting them out for weeks and weeks and weeks. Many of our residents are in their 90s, but they are as self-determining and wish to be as autonomous as they can be and as they were earlier in their lives. And I don't think it's adequate as a system or as a country to say that the way that we protect our old is to keep them locked up in care homes for as long as it takes. Now that will create amazing opportunities for design, for technology, for architecture, and so on. And I know that all those involved in that will rise to the challenge. And that needs to be allied to the third element. You know, as has been said, we have, social care has been right at the back end of the impact of digital technology, either in the way in which people are able to communicate with those who are in care homes and their families and loved ones outside, sometimes at a distance, but also in terms of areas like consultation, virtual triage, remote treatment and monitoring. I mean, one of the biggest challenges in care homes is the huge number of residents who make horrible trips to hospitals, often in the middle of the night when they've fallen or they've got some kind of physical ailment. And the old adage of 10 days in hospital is worth 10 years has some truth in it. So I'm hopeful that one of the real profound differences that will come out of this will be a great acceleration in the application of digital technologies to enable it, to make it easier for our team members to be able to deliver their work, to keep residents more safe and protected, to enable residents and their families to have greater touch points and stay connected, and to ensure that virtual healthcare has real application for those who are living within care homes. Thanks very much, Henry.
Natalie-Jane, thank you very much for that. I think that very, very neatly encapsulates actually some new themes from the previous panelists. And just to try and summarize those, I think we do have a PR battle on our hands, we really do. And it behoves the whole sector to make sure that some of the damaging PR out there is fixed, that people understand that actually it's a lot safer to be in a care home now than it was 3 months ago. And that's a combination of having access to PPE, testing residents and staff, and it's evidenced in the data that's out there. But I think more generally, the social care sector has a PR window of opportunity, as Martin would put it, to really stake its claim in the system, and we mustn't lose that. And I say that in the context, I was on a call with Nick Timmins, who was the FT correspondent for healthcare for many, many years. And he was asked whether he thought this was going to change everything. And he said, look, I don't wish to be too downbeat, but I would just look at Grenfell Tower, a hugely emotional event which people responded to nationally. And yet here we are today with cladding on many towers around the UK unchanged. You know, life returns to normal, people move on. And I think we have a challenge as a sector to make sure that social care doesn't get lost. So there's the PR battle, there's the technology piece. And, you know, I think, you know, Farooq, your company is called CareTech. And the thing is that actually it's quite tough to find technology that really moves the needle in care. But there are people out there. So LaingBuisson have been working with a company called AgeTech. It's actually an EU-funded project by a professor at Warwick University. And they have a database of over 1,000 technology companies with innovative products. And I think the sector needs, in a way, to share best practice and make sure that technology is used and people are aware of it. But there is a real opportunity there. So I think there are lots of exciting things that could happen, and I just hope we don't fumble it. And on that, I'm going to turn over to Katia, who's really got a perspective across the broader market, but I think will now sort of give us a view on where we, the consumers, are sitting in all this and what our perspectives are on what's happened over the last few months. So Katia, over to you.
Yeah, thank you, Henry. And good afternoon, everyone. I am firmly pivoting us away from social care, I must admit, in my little 5-minute piece. I'm a partner at L.E.K, and I spend most of my time in clinic-based healthcare services, so things such as dentistry, IVF, dermatology, etc., which are quite often privately paid. And we do a combination of strategies, a growth strategy work or transaction support work. And as you can imagine, in both of those, inevitably, every time we get asked the question about the outlook on demand and the evolution of demand over time, which of course right now is incredibly hard. I mean, it's quite hard mostly in the normal times, but right now it's particularly hard because you're facing kind of mandatory clinic closures and capacity constraints as they reopen, even with having to space out appointments or source PPE, which you might not have access to, etc. You have pressure on income coming through for the consumers, potentially more longer term, as currently people are on furloughs and various support schemes, but longer term pressure on incomes will come in. But at the same time, there is an urgency to certain types of treatments, and there is a certain amount of pent-up demand. So kind of how the two sides of the equation are going to balance out, and what demand we will see from consumers from patients as consumers in the foreseeable was one of the key questions we are kind of battling with now. So we ran a little survey. This was, I think it was late April, early May, although we have done various rounds of surveying since then, and the results still very much hold up. It was done, it's an online survey done with just over 1,000 patients across the UK, kind of representative in terms of gender and age and all of those good things. And the main things we were testing for are, well, firstly, what proportion of patients had to delay or cancel their treatments during COVID. I mean, that's reasonably straightforward and obvious, right? Because in a lot of those sectors that I mentioned, you just couldn't access treatments unless they were urgent ones. But there are obviously some treatments that go on for a long period of time. So if you think about orthodontics, you might have been given by your orthodontist a certain set of, I don't know, clear aligners to wear, and you have been wearing them for 3-4 months, and actually COVID didn't impact your treatment at all because you were sort of in the middle of it. But more importantly, we were interested to know how quickly patients will come back to the clinics, and how quickly they will come back to these services, and then also and how this varies by type of clinic. So what we found is patients are quite optimistic, I must say, and this is potentially the kind of as I say, the relation with various income support. So they're quite optimistic about not having too much negative impact on their income due to COVID. and therefore wanting to spend the money on all these services as soon as it's safe to do so. So a third of the patients overall said that they would like to return to their clinics as soon as they reopen, which was quite a pleasant surprise for us. And then obviously subject to the clinics having capacity to receive them. And another 30% following as soon as movement restrictions are lifted. So a reasonably quick comeback. But I'll show you a couple of slides which also break it down by treatment types and by subsegment, which becomes more interesting. We wanted to know also whether overall patients would be spending less money, and this is again mostly self-pay, out-of-pocket pay services, less money in the next 6 months as compared to same time last year. And it will be marginally less, but actually much less as I would have expected it to be. Although obviously some more elective sectors are more affected. So laser hair removal and such like, which are less healthcare and more cosmetic. And then we also asked some questions about what we as providers should be doing to reassure the patients about it being safe to come back and start re-engaging with the services. And there's some material on that, please. Henry, would you mind skipping to the next slide? Thank you very much. So this one is showing you across the different segments within healthcare, from dentistry to ophthalmology to fertility, etc., what the expectations from the patients are in the next 6 months. And you can see the colors vary quite a lot, but also if you look at the net impact line underneath the chart, so this is kind of the positives minus the negatives, ignoring the no change ones. The net impact is negative for quite a few of them, but there are some notably which are positive. And I think fertility treatment is a very point because there is such an urgency to that treatment that people do want to come back and are willing to spend the money as soon as they're allowed to, because it's not something you can delay very easily, right? Whereas some of these services, particularly the more cosmetic ones, you can delay until the safety improves or incomes recover and things like that. Next one, please, Henry. And this is a similar question, slightly different question, but similar theme. So the question was, how quickly do you as a patient of all of these services expect to return to them after clinics reopen? And you can see, again, a lot of variation, fertility very high on immediately returning as soon as the doors open. Some others are a bit lower. But on average, roughly 30% of patients wanted to come back to treatments immediately as soon as they're allowed to. And then another 30% sort of in the next couple of months when movement restrictions are lifted. Can't remember if we had another slide. I think we possibly didn't have another slide in the loop here actually, because I'm trying to keep to time. But there are some materials there's like a slightly longer pack that Henry will circulate in due course to all the seminar participants. And hopefully that's helpful. I think overall quite a positive picture to you know, I thought this would be a lot worse, but obviously a relatively slow return, kind of, you know, a stepped return to treatments as we go through the year. We're watching this very closely, as you can imagine right now, as the clinics are beginning to reopen. I think dentistry was one of the first ones, and they're having to put in a lot of restrictions on how the patients can engage with the clinic. So there are some capacity limitations to how much volume you can process as well. But quite an interesting kind of space to watch, I guess.
So Katja, thank you very much for that. I actually think this is a fantastic insight into where people's minds are at just generally in relation to health and care. And whilst it relates to clinical procedures, it probably maps very accurately across to where people are in terms of how nervous they are around social care as well. We just had a question come up on the chat saying, from Irving Stackpole, who's a consultant in the sector, saying that he's seeing cosmetic and hedonistic demand increase first and quite robustly. I suspect that's because, you know, some people haven't been spending money whilst they've been under lockdown, and now they have the opportunity to. That's the first thing that's on their list. So do you think that actually is slightly at variance maybe with where they thought they would be back in April?
I think it actually depends on the type of cosmetic treatment. So plastic surgery always surprises us. It did in the last recession, and I suspect it will here as well. Because I think it is, once you've decided that you need it and you've saved, you are very likely to go through with the treatment, because it is quite, again, I mean, not quite the same as IVF, obviously, but it's quite a big deal for people to actually go and have this treatment done. So plastic surgery, we tend to see recovering a little bit faster. I think some of the others, such as, again, laser hair removal is not a great example, but let's go with that. Laser hair removal is probably more delayable by a couple of months, because it doesn't make that much of a difference to your overall appearance. So I think it will slightly vary by treatment type, but yeah, overall it comes out worse than healthcare treatments as such.
Very good. Thank you very much, Katja. I was just going to ask Natalie-Jane Macdonald a question with her new hat on as the chair of Nuffield Health, which is the largest not-for-profit provider of hospital services in the UK. And Natalie, whether you think, looking forward, the relationship that the private or the independent sector has with the NHS is going to change, and whether it will change for the better as a result of this pandemic.
I think I'd agree with Katja in terms of there is quite a lot of demand for people who've not been able to access elective healthcare services of different kinds, that many people are ready to come back across a range of services. I think that, healthcare is, although we talk about a national health service, it's intensely local. And certainly what we've seen, and I think other providers have seen as well, is that locally there has been tremendous collaboration and working between NHS trusts and their local independent hospitals, certainly for Nuffield, whether that's been in relation to managing patients with COVID, or often in transferring important NHS services that can't be delivered, such as cancer services and other high-end services, out of their traditional homes into private hospitals, and giving the independent hospital teams, challenges of services that are very different from normal. And I think there's been really strong collaborative working and the building of very good relationships with teams actually going between the two sectors. That can only be a fantastic foundation for the future, where often we've seen where there have been issues in healthcare, some of the terrible things that happen. A lot of that is often about poor communication and poor collaboration between the private sector and the NHS. And I think that is something I think we're going to see very different moving forward. I think also, clearly, there's a huge number of patients who haven't been able to be treated in the NHS over the past months. There's going to be a lot of demand, long waiting lists. And I think independent hospitals will continue, whilst trying to return to their normal mix and be able to treat patients who are insured and who self-pay, will continue to provide elective services in different case mix across the country. And I know coming out of the current contract with NHSE, that is the intention. So I hope that there will be collaborative and productive arrangements moving forward. And one of the things that Nuffield has done is to launch a rehab program specifically designed for patients who've been in hospital with COVID. There's both the physical effects of those who've been in critical care units and in ventilators or seriously ill, but there are the profound psychological impacts of COVID at a time when families weren't able to visit and people were extremely isolated whilst being very ill. So obviously that's the sort of program that can work alongside the NHS and is available for all patients to be able to access to help them recover and gain back to strength over the months to come.
Thank you very much, Natalie. And I think one of the takeaways I have from that is if the independent healthcare sector can coordinate so seamlessly with the NHS when they have to, is there hope for social care to do the same with the NHS in future? I'm just going to quickly put up the poll for where we've come out. Again, digital and data are taking the lead there, followed by funding, and then, funnily enough, better coordination between health and social care. So we're now going to move on to the Q&A in the last 10 minutes or so. And actually, I think the first question here is actually pretty pertinent. Are we sure the image of the sector has been rehabilitated You know, are polls really accurate when they say it might actually have cemented a negative view of care homes? So we've got 9 people voting for that question. And clearly we want it to be a positive story, but we are not the audience. So maybe actually, Martin, I might start with you on that one, in terms of your perception representing your members. How do we turn this around?
Well, I think we have to turn it around by getting our key messages about the impact and the quality of life people have in care services. I think we've also got to make sure that it's the people who live in services and their families that are leading this message. Undoubtedly, throughout this COVID crisis, we've had a focus on care homes, but it's usually been about issues around PPE not getting through, or the numbers of people who've died, etc. So I think we do have a major challenge around how we, shall we say, reposition ourselves and get people to understand what we do. And I think it's going to be a fairly long job, but we've all got to apply ourselves to that.
Thank you very much, Martin. Farooq, what one for you? I think, you know, we heard a lot about your business and how you've been relatively insulated, but I think people are always interested to know, when people mention digital and technology, what did they actually do? What was the technology? And a question here is, what did you use to help you during your staffing shortage? How did you engage with your staff and potentially recruiting people to fill the gaps while they were all sheltering or ill?
Yeah. So look, I think the first thing I'll say, Henry, is communication. I think we found that with the lockdown, we were in a situation where really we could have gone into a bit of a sort of a under the radar. So we had a daily briefing with the senior team. We had a weekly message that went out from the centre that Haroon sent out, that reached to all of the staff. And I think at times like this, you've got to really be visible, and people have got to feel that you are there listening and you're supporting. We were quite lucky. We have got, and it goes back to really the ethos that we were creating in the organization. We were pretty well staffed as we went into the lockdown. So we weren't dealing with the number of vacancies. So, I mean, I think through that lockdown, our HR and recruitment found there was a massive surge of applications that came in. Obviously, we couldn't do physical interviews, and they were being done online. And so I think the things I'll put towards this is about communication, people feeling valued and supported. I think we had teams that, I mean, we had one of our non-execs do a Zoom visit to one of our homes. So, you know, the fact that we were able to not visit, but do it via Zoom. We worked with the NHS, Microsoft, and Facebook, and did a pilot with them about technology that we rolled out in 50 of our homes, which enabled some of the residents who were on lockdown to communicate with some of their staff, with some of their sort of family and carers. And so look, there's not a silver bullet on this. It's a number of things that you end up doing. But I think if I was to list it, I think first and foremost would be communication, being visible, and being there where people feel that they're being supported. I mean, we had a team of people where whenever we heard there was some good work going on, a box of chocolates, a little token or a gesture that was sent out to the home with a personalized message. Doesn't cost a lot, but I can tell you the number of messages we got back from people where you were seen to be thinking of them and responding and feeling that you're there with them made a massive difference.
Thank you very much for that, Farooq. I think the next question that's come to the top is a theme we've heard all day, is this collaboration between health and care and technology, two of the themes. And I was going to ask Katia for her thoughts, because she's a strategy consultant, and this is exactly the question and the challenge that she gets asked by her clients. We all know what we ought to do. What we haven't worked out is how to do it. And I just wondered, Katia, whether you had some thoughts about how we make this collaboration work and how we actually deliver technology. And the one caveat I always get from people when I talk to them about this is, someone's got to pay for that technology for a start. So you can't just say, use it.
Yeah, that's an interesting one. With my very optimistic hat on, which I do love to wear, I would hope that this would result in better collaboration between healthcare and social care, but also between NHS and private providers of acute care as well. In terms of how it can be facilitated and who pays for it, obviously, particularly the healthcare to social care patient movement always trips on the shift of budgets. So I think there isn't huge amounts you can do technologically in terms of making that transition smoother until the budgetary issue is resolved, right? So if healthcare at some point starts paying for that step down into social care, which would be beneficial because it saves you a much higher cost of hospital stay, then yes, there could be some creative technology solutions, right, in terms of how you triage the patients and move them. But that decision needs to be made first. I think there is some really cool things coming up in rehab, in tele methods of engagement with things such as physiotherapy, for example, which didn't exist before because they just didn't need to, and COVID has really accelerated it. So anything from doing your physio exercises in front of a screen that will record you and kind of correct you if you're doing them wrong type things could be really interesting. But I don't think it's the technology that will solve the problem. It needs to be the fundamental kind of willingness to cooperate better between the different parts of the health and social care system, really, and technology can then facilitate it.
So I think let's stick with your optimism, Katja. Right. We're coming up against time, so I think the last two questions really are linked, which is around funding and whether we are seeing operators out there in distress at the moment. And I think if I just go to all the panelists in turn and just get their views on this, because this really comes to the nub of the issue. Are we going to have a properly funded sector? So Boris is making noises about actually doing something around social care reform, and part of that will be funding. Part of it may well be regulation as well. What do we think is going to come out of that elusive white paper? The green paper got delayed 5 times, if you remember, and now turned into a white paper. Where do we think we're going to get to on funding? I'm going to start with Martin because he talks about this more than anybody, and hopefully it'll be a suitably optimistic line like Katja.
Well, thank you for that, Henry. And I am somewhat optimistic, but what I really want is not a tinkering round the edges of a current system which is underfunded, but also has lots of other issues apart from funding. So what I'd like to see is a really clear new vision for social care, looking at what it delivers for citizens, the outcomes, how you enable people to live well, particularly people who've got a multitude of issues and often have challenges around their life. So I want to see us thinking strategically about a vision, what we want to deliver, and then working backwards, thinking, well, what will this cost? Looking at also the interface points and saying, if we can do things better and cheaper, we need to remind ourselves that better is the most important, but if we can also save money and do things cheaper, then so much the better. So I think we've just got to not look at this in the context of where we were currently, which was to talk endlessly about funding a system that was not fit for purpose in the 21st century. Let's start with a blank sheet of paper and build something that people and citizens really want.
Okay, I'm going to stop you there, Martin, to give others a chance, but essentially a new vision, better ways of doing it, and then work out the cost and the interface. Farooq, I'm going to come to you just because you can address education, adult social care in 15 seconds. How optimistic are you?
I'm the eternal optimist, as some people know. But look, I think we are part of the solution as well here. We have to accept that we've got a rising demand and a rising need, and no matter whatever the government do, there's never enough money. I think Martin hit the nail on the head, and I think we are very much committed to doing that. We have to also be able to provide care pathways, support to individuals, not hold on to them. and move them through the care pathway to independence and reduce the cost for local authority. And I think that, we're finding that actually there is money available. I think I'm hearing our fee negotiations this year are easier than they've been historically. They're never easy. Whatever the government does is never enough. I think we have to also come forward to come with models of care where we can become more efficient, and actually create pathways and help people live independently. And that's a win-win for everyone. It's a win for the individual because they're living more independently. It's a win for us because we're doing what we're saying, and win for local authority and us as taxpayers because it's making our money go further.
Well, Farooq, I think in some ways that's a very nice way to end, because that really sort of summarizes really what the sector needs to do. We need to step up and we need to deliver as well. And I think on that, we're out of time. So I just need to thank our partners, and particularly Charles Russell Speechlys and Michael Lingens, for partnering with us and sponsoring this webinar. Two media partners, Care Markets and Healthcare Markets. And just to say the two charities we've supported throughout this, so the Care Workers Charity and Turn to Us, who have both raised millions of pounds and are helping lots of people at the moment, and tragically potentially many more as the redundancies start to roll out and furlough rolls off. And then just to finally say, our next webinar is on the 16th of July and will be about how we reboot and relaunch the London private healthcare market. So thank you all for attending. Delighted to see so many of you on the webinar. And thank you also to our fantastic lineup of panelists.
Thank you.